take and swallow the word volume and swallow the word capacity. Because volume speaks directly as to a number of what's actually there. Capacity speaks to a number of what could be. Like, you've got a capacity, meaning you're capable of. But volume tells us what's actually there. And I do this best from chapter 4 in our physical disabilities book. And I don't know if you still have that. It's going to spit the same stuff out at you, so you don't really have to do that. But what I would look at here, Scott, how come you turn the heat on?
It's
Fair enough. So capacity, that's your limit. Like, we have a room right here, and it's got 4 walls and a ceiling, and this many chairs. That's the capacity. There are empty chairs though, right? We only have so many people in here. That's the volume. And that's really what you got to start with. You got to say, okay, I'm dealing with this. Because when they ask you a question, almost always you can direct the 2 answers that are not right by just judging the way they're asking the question and seeing if it's a volume-related question or a capacity-related question. How many of you hit a question on this already? Do you remember it by chance?
No, but I had a lot. There was a lot of little bit of stuff. And it would just ask you like...
Sorry, I'm giving you a hard time. So what do you got?
It would
Remember?
just ask you like, which ones would make up, like if you added these together, what would it be? Or like, which one would be the greatest? And then it would have 3 of them. You'd have to pick between them.
I think there's one like, there is whichever is like 5,000 and this one is 4,000. What is the other 1,000 part of or something?
All right, so I'm going to tell you something that I don't particularly like this reality. You have to hedge your bet.
You have to what?
You have to hedge your bet. What's your bet going to be? Are you going to spend more time locked into trying to memorize these specific numbers? Like, and it doesn't even, I don't know that it's really listed in the score builders as much. I mean, it goes into the volume numbers on the next page. It goes specifically to 500 milliliters, to 2,500 milliliters, 1,000 milliliters, all of these different milliliters, kind of like what Aaron was saying on your volume of air in the normal adult male in your physical disabilities book. Are you going to spend your time working that out and memorizing these numbers that by and large could get quite confusing, or do you want to spend your time on something else, right? And that's honestly what I'm just going to lay out for you. I had 0 questions on my licensure exam about this. I'm not saying you will or won't. In fact, most of the cohorts have reported back that they had a question. I can tell you that. It's probably 1 question in reality, because they only have between, I don't remember, 20-something questions that they can do on cardiopulm. And so that's just not where they're going to spend their time. However, it could. Now, also, in hedging your bet, you also have to bet, was that a graded question or was it not? Right? So I'm just laying that out there as a truth. I'm not telling you, I'm not saying don't study this. Some of you may look at this and with your very good, I think many of you in here have photographic memory, and you can look at that and you can be like, bam, and you can lock that down. If that's you, do it. Do it. But listen, some of you are going to look at this and get very frustrated. So with that, let me just say it this way. First, judge it on Is it a question about the limits, or is it a question about what the volume is? And so that's how you have to start. So you go in here and you look and you say the anatomic dead space volume. Well, that's how much is existing there, and it's the volume of air that occupies a non-respiratory conducting airway. So that's dead space, which that kind of makes sense. Your expiratory reserve volume, that's how much air is left in the lungs after, so it's a volume, how much is left in the lungs after max expiration, right? Okay, so I'm going to stand way back so that Vanya doesn't get my COVID. And I'm going to remove this for a minute because I can't demonstrate this with this mask on. I'll keep it right here. How about that? And when you do this, what you do is you inhale and then you exhale maximally. And that little bit that's still in my lungs after I do that, that's your expiratory reserve volume. It's a volume that's left there because your lungs can't empty out totally, or you're going to have a pneumothorax. What's that?
Collapse.
Yeah, a dramatically collapsed lung. Your lung will collapse. It needs air pressure in it. So it's a volume. Same is true with inspiratory reserve volume. You have a volume of air that can still fill the lungs, and it's kind of in reverse. So I inhale, and I can pull just a little bit more in there. I can put just a little bit more. I mean, like you're pouring your coffee, and you got just that much left in the cup, and and you're like, let me just get that little bit. You can get that little bit left. That's a volume. So that's the two differences there. You also have a forced expiratory volume, and that's, look at this, the max volume of air exhaled in a specific period of time. In fact, usually what they do is they say FEV1, and that 1 is for 1 second. That's how much volume can you force out in 1 second, right? So they're putting a balloon basically on you and saying, blow out as hard as you can for 1 second, let's see how much it is, right? That's a volume. So those are all pretty easy, right? If I just think about those words, I'm like, that's all good. Starts getting a little nasty here. Your forced vital capacity. Now wait a second. That's a new word. Capacity. That's how much it could be, right? Like we have space for this. We have a room. It's this many feet across, this many feet deep. We have space for it. The volume of air during a forced maximal expiration after a forced maximal inspiration. Well, this is best looked at if you stay with forced vital capacity and you go all the way down to the bottom and you see vital capacity down at the bottom. It is the volume change that occurs between maximal inspiration and maximal expiration. And then it gives you this formula. And I'm totally good with you memorizing that. But that is a volume that goes in and then goes out. And so there's two measurements. And then we say this is how much you could have held right here. That's your capacity. And then you go back up and you say, if I did that with force, that's my forced vital capacity. But the problem is this also sounds very familiar when we look at the other term above vital capacity that's known as tidal volume. Tidal, what do you think about when you think of a tide? Waves. All right, so we're going to get the ocean for just a minute. So you got these waves coming in. You know what's cool about the waves is they just keep coming, right? Like you can stand there and it just keeps coming. It keeps coming. It keeps coming. So think about that. You've got this tide and it's coming in and then it's going out. It's coming in, it's coming out. It's coming in, it's coming out, right? And I'm not saying the tide goes in and goes out. I'm just saying like you feel the tide. It hits and then it kind of goes back out and it comes back in and it goes back out, right? Those of you who've been to a beach, you know exactly what I'm talking about. Take a look at the definition. Total volume inspired and expired with each breath during quiet breathing. So that's one I would definitely be good with. If I'm just sitting here breathing and I'm standing on a beach, the waves are going to hit me and they're going to come out, and they're going to hit me and they're going to come out. Tidal breathing, that is, or tidal volume, that is the volume inspired and expired during quiet breathing. So you're just kind of leaving that out there for probably your easier term. You go back up to your inspiratory capacity, the max volume of air that can be inspired. Right? So that's how much can you fit in the room. That's your inspiratory capacity. And then one more that I want to address is residual volume. The volume of gas remaining in the lungs at the end of a maximal expiration. The volume of gas left in the lung. So that's where I'd really kind of look at and I'd say, okay, I'm going to hedge my bets. I'm going to remember these. Aaron said there was some unique formulas. And I agree. And if you look, the big formulas on there come in at functional residual capacity, at minute volume ventilation, and that's actually the easiest one to do. I don't know, if Aaron, if that was the one that you had. Your total lung capacity and your vital capacity. Those are the ones that are listed with different formulas. So you might want to develop a note card that says total lung capacity, that's the volume of air in the lungs after a maximal inspiration, and then you might want to have a total lung capacity formula note card. And then on the back of it, just have these numbers, or basically these same abbreviations down, RV plus VC, or TLC equals FRC plus IC. And then I would just lean on my options to kind of get me through that. It's a tough go. It really is, because it's such a small risk. But in our world of licensure exams where people have failed by one question, what are you willing to bet? Can I answer any questions on that?
I have a question about the heart stuff. So when you have ventricular fibrillation, it's not going to be from that what do you call it, blockage, or the regurgitation?
Well, no, that's just a product that goes along with it. Fibrillation, you'll also have a regurgitation.
Okay. Even the ventricular fibrillation, is that what?
With ventricular, you will have a certain regurgitation. I don't think it's the same. I don't know a lot about ventricular fibrillation. It's not one that you hear about a lot, and honestly, I just don't study it as much as I do the atrial. So I'm kind of gapped on that one, I'm sorry. All right, well, let's drop the bomb on some pathologies then. That's the next page. First one, aneurysm. And I want to tell you this probably plays out more in the clinical type questions where you're working with a patient after something like this has happened. Although I wouldn't say that it's not something you might see a patient subdue to, but what they're specifically talking about there is, it's in the description, the abdominal aorta aneurysm. It's also known as a AAA. An abdominal aorta aneurysm. And so it discusses in the etiology what that's from. A weakness in the wall of the vessel, often due to chronic hypertension. It also lists something called Marfan syndrome, which you may have never heard of before. What you would almost have to do, and the phenotype that really describes what Marfan syndrome is probably that of maybe a college or even an NBA basketball player who is very tall, has a very endomorphic frame, and they have kind of this cavity chest, right? And they have really long arms. Typically, their arm length is, normal arm length is just past the greater trochanter. Theirs go mid-thigh. Their arm length is equal to or greater than their height. So that's kind of the typical Marfan syndrome phenotype. So you probably haven't heard of that one very often, but they do have some unique cardiopulmonary risk that goes along with that condition.
My husband has Marfan syndrome.
Really?
Yeah.
Does it?
Yeah.
So what's it called?
I guess. He's 6'5", skin and bone. He's got huge hands, and I've read that that's like a thing too.
Mm-hmm. That's wild. I mean, I've suspected it in tons of people, but never had the diagnosis given to me. That's cool. Not cool.
Yeah.
Not cool. I didn't mean it that way.
Huh?
When did you find out that you had it? Was it birth?
I think he's known since he was a kid, but maybe not that young.
Another thing about the aneurysm, it does say it's variable based on the site. So you're not just looking at the abdominal aortic aneurysm, you're looking at an aneurysm anywhere. But very specifically, I just want to draw your attention to that one. And then see where there's sudden severe headache, vomiting, stiff neck, seizure, loss of consciousness, double vision. Listen, any of those things always raise red flags, right? What you're not going to know is it an abdominal aneurysm or not? That's not your job to do. Your job is to say, this person is distressed, we don't need to do therapy. It's a medical thing. And by the way, Ms. Hobday and I talked about that question from last week. And I can give some more feedback as to why she positioned it that way, if you want. I mean, we had a long powwow, a long one, about like how that works. And she sees my point, but then I have to confess I see her point on that question specifically. But if it is, it's a medical emergency, it's a 911 thing, so it's an EMS thing. But look at the abdominal pain, the sudden onset. Also, the big part about loss of consciousness. That's pretty common. I mean, if you're having an aneurysm, you're probably going to lose consciousness. I'll let you kind of work through some of the treatment things there. Next one, angina, is listed, and again, they talk about it basically the same way I did, stable and unstable. Remember, we talked about that across several different areas for you. But stable, predictable, unstable. They have no idea it's coming, even at rest. I do want to draw out on the signs and symptoms. Obviously, you know the etiology being a oxygen issue, so that word ischemia pops up. With the signs and symptoms, though, please remember this is chest pain, and it will imitate heart attack. You're also looking at, if they do know it's coming, it's stable, a drug, specific drug. What do you know you're going to get there? Nitro. Thank you very much. Atherosclerosis. This is your narrowing of your arteries. And the specific narrowing, it talks about in the book a thing called plaque. I think what you're going to see is more of a look at inflammation, chronic inflammation in your careers, but that's just not really talked about as much in the book. Some of the background, all cardiopulm stuff really leans back into, was the patient a smoker? Do they have a family history of it? Are they obese? Do they have other risk factors, including type 2 diabetes? Like, that's kind of the big four that we see with all of the cardio stuff, and even some of the pulm. But when you look at just the heart, you're asking, do they smoke? Are they obese? Do they have family history? And are they type 2 diabetic? Like, that's the big risk factors involved with this. So that's also the etiology. Like, that usually lends itself to it. Your signs and symptoms of atherosclerosis, it gives this wonderful description here, and it means absolutely nothing, because the problem is the only time people have problems that show in signs and symptoms of atherosclerosis is when they're either on the morgue table dead, or right here where it talks about basically having a stroke. Right, so it's not direct to atherosclerosis. Atherosclerosis is one of the two silent killers. Like, people most of the time don't know they have it. And there's not really a great testing scenario for it either. So, your treatment, I do want to address this. Lifestyle changes, that's exercise, diet, and sleep. But then you go into medications, and sometimes they do surgery. That's a pretty heavy one, but the lifestyle changes also include smoking cessation, and we've talked about that in the past. I'm going to kick over to this next one, chronic venous insufficiency. I don't really need to go any further into this one other than to say this system right here that we talked about, the one-way valves, they're insufficient, meaning they're not getting that blood to the next level, and so you run a risk of having blood stasis. Now let me say another word with that, which also means there could be like venous stasis. You finish it. Yeah. Everybody catch it? Ulcer wound. Cor pulmonale. That's probably some. Has anybody ever heard of this one? No? Well, let's just do this. Pulmonary heart disease refers to hypertrophy of the right ventricle caused by altered structure or function of the lungs. And so it's a lung issue that transitions over and expresses into the heart, specifically right ventricle hypertrophy. So going back up here, a lot of times we'll see hypertrophic cardiomyopathy, but it's associated to this right here, the left ventricle. So we're not seeing it there though. In fact, if you look, it's hypertrophy of the right ventricle, and that's because there's a backup in the lungs, and as the blood comes in, it starts to have to push harder. And so your left ventricle is more common with hypertrophic cardiomyopathy. Did I say that right? Your left ventricle? Yes. Your right ventricle is the one that is associated with cor pulmonale.
Can you say the left one again, what it was called?
Hypertrophic cardiomyopathy. The condition is more common not as a standalone condition. It's a lot like cor pulmonale. It is a byproduct of something else. Your CAD, your coronary artery disease, this is another one that we see. Remember, we have our coronary arteries, so these things right here are getting blocked. This is the precursor, along with atherosclerosis, to heart attack. CAD, it says narrowing or blockage of the coronary arteries due to atheromatous plaques resulting in diminished blood flow. Another thing, though, that I would say is you may just hear it coronary atherosclerosis. That's just another terminology. Most of the time when they're talking about atherosclerosis, they're talking about peripheral arteries. With coronary, they'll preface it with coronary. And you can see the risk factors or the etiology, same risk factors that I talked about right there. But it also, I didn't talk about this one, hypertension and cholesterol. They both always fall into that. So I said 4, but I'm going to go ahead and label that to 6. My apologies there. All right. We're going to run right through this. It's going to be good. Look at 364, turn the page, and let's talk about DVTs. I feel like we've got a really good grasp on DVT. I really do. However, I do want to kind of talk a little bit more about it. I know in our Therex class, I dropped a series of veins, right, that you may see this specific at. I would go back and reference that if that's not coming to you real clear right now. But the largest thing that we've got to walk away from is, what does it look like? So take a look at signs and symptoms. And if at any point this has not stuck with you, you make this stick. This is like your last little opportunity here for DVTs, because I promise you, you might see a lung volume capacity question. You will definitely see a DVT question. And it will probably have to do with, did the PTA save the patient or kill the patient? That's a lot of times what they're looking at. About 50% of the DVT cases are asymptomatic, and so that's scary. But when they do come up, swelling, pain, redness, warmth. So why do you have swelling? Why do you have redness? Why do you have pain? And why do you have warmth? Because there's a blood clot. And so blood is just running in and it's staying there, and that's where you get the swelling. That's where you get the heat. That's where because more blood is coming to that area, that's where you get the heat. That's where you're getting the redness, and then also the pain. Because this has I'm not going to do any justice to this illustration by doing this, but I'm going to do it anyways. Your vein, blood came in, and it's literally stuck because it can't go any further. There is a blood clot right there. And so that blood is just continuing to pump in, pump in, pump in. So you get swelling, which causes redness, which causes pain. And pretty soon, this thing dislodges, travels up here, right through there, and that's where your patient's going to die with a pulmonary embolism. Are you good on that? I do want to point this out. Look at treatment. What are some of the treatment options that are going on? And they give one really unique word called an anticoagulant. What do you suppose a medication that's called an anticoagulant does?
Stops the blood from clotting.
It stops blood from clotting. So I would definitely connect those dots onto that.
And you just stop right away whenever you think they have one?
Yep. You probably caught that in your subjective assessment. No, I'm sorry, I said that wrong. In your subjective conversation. Hey, how you doing today? How's your pain? On a scale of 0 to 10. Anything else going on that we need to know about? But also you have like this filter that goes on that you're like, okay, is this person at risk? You know, have they been in the hospital? Have they been bed resting? Are they largely sedentary? Have they recently had a lower extremity surgery? Anything else that you can think of? Like you're going through that the whole time. And if they fit any of that, you're probably saying, hey, how's your calf feeling? Or if they come in and they report, man, my calf hurts. Like that sends up all these red flags. You say, okay, we're going to address that first. And if you're going to leave that patient, Dakari, and go home and worry about it, Don't do treatment, call 911. You'll be the hero or the zero, but at least you'll be able to sleep that night, right?
Mhm.
All right, this next one. Listen, I feel like I'm saying this a lot. It's really critical that you grab on to heart failure because it comes in two pathways. You have right side heart failure and you have left side heart failure. Now, if you ever ran a vacuum and the vacuum just starts not sucking as good and it's just not picking up the stuff, you guys feel me? Maybe the bag's too full, maybe the filter's dirty, or maybe it's just an old vacuum. That's heart failure right there. That's the best description of heart failure. It's just the heart is not stopping. Please do not get this confused. There is a condition known as sudden cardiac arrest. That's when the heart just stops, flatline. Heart failure is not that. Heart failure means it's getting weak and it's just not doing its job very good. It's still doing its job, it's just not doing it as good. Many students really struggle with that word heart failure. Your heart still pumps. It's just getting weak. And that comes from a lot of different things, but we're just going to look at it from this right here. Coronary artery disease, hypertension, diabetes, a previous or a past medical history of heart attack, abnormal heart valves, and then cardiomyopathy. That's your big ones. But the patient is usually just diagnosed with heart failure, and you don't know if it's right or left. But here's the thing. The licensure exam expects you to know this part. So if it's the right side, where does the blood come from on the right side? Go simpler. It's from the body. On the left side, though, where does the blood come from? The lungs. What's happening here is we got a vacuum cleaner, and it's not getting blood up here. Because every time this heart pumps, it also has an eccentric version where it pulls blood up. It's not just pushing. And so the pulling of blood from the body, if it's weak, blood stays in the body. So guess where it likes to stay? It likes to stay in anti-gravity dependent positions, like your lower legs. It really likes that blood. It also likes your belly area. And so you will see this patient who has right side heart failure, they'll have lower extremity swelling. Sometimes they'll have some swelling in the gut that's not really identifiable most times, but you can definitely see it down there in the legs. In fact, most of you have seen it. And guess what? Their legs are really red and dark. And so that is what right side heart failure looks like. Left side looks a little different. Guess where it's not pulling blood from? The vacuum's not working from the lungs. So it doesn't pull it from the lungs. So there, you get a condition. Now let me be very clear. Moments ago, we talked about something called a pulmonary embolism. We labeled it PE. I'm going to give you another PE. It's not commonly known as PE, though. Pulmonary edema. Now, that can only go so long before somebody's going to die. So you have a dangerous condition known as pulmonary embolism that is signaled from a DVT. You also have another one called pulmonary edema. So let's catch that before we go any further. Turn the page over, and you're going to see it at the top on the next page. And just in the first paragraph, it says, acute pulmonary edema is a medical emergency. So just like DVT, just like pulmonary embolism, you have to know pulmonary edema. Like this is on my short list of, oh crap, I better call 911. Right? So pay attention to these signs and symptoms. Depending on the cause, symptoms can develop suddenly or slowly. That sucks. Let me just tell you. In testing purposes, I like these things that come on really, really fast. They tell me like something's really, really wrong. The problem with pulmonary edema, it could be a very slow process coming back to the lungs. So you can't really put sudden on there. With pulmonary embolism, that clot went loose and it got in their lungs and it came on pretty fast. Right? So let me lay out some groundwork that the test is going to do to you. They're going to say this person is in respiratory distress. Well, that could mean pulmonary embolism, it could mean pulmonary edema. The reality is, as long as you got to the hospital, in clinical and in your job, it doesn't matter if you know what they have going on. But the test really is going to pick on you about this. So, with pulmonary embolism, very sudden. Pulmonary edema could be slow. It also says it occurs when the left ventricle is unable to pump blood adequately. Left heart failure. As a result, pressure increases inside the left atrium and then the pulmonary veins and the capillaries, causing fluid to be pushed through the capillary walls and the alveoli. There you get pulmonary edema. And this may result from pneumonia, medications, smoke inhalation, respiratory distress syndrome. And there you go, Dakota, living at high elevations. Anyways, develop suddenly or slowly, signs and symptoms that come on, shortness of breath. We described that last night in the study session. That's called dyspnea. Most of the time, the licensure exam is going to just say dyspnea. So just be sure you're good with that word. Difficulty breathing, suffocation or drowning, and then here you go. If you see wheezing, gasping of breath, anxiety, restlessness, sense of apprehension, and then coughing. I got to tell you something. On every lung issue, they're going to throw down coughing, right? It's just like people cough, whether they have pneumonia, whether they have COVID, whether they have pulmonary edema, pulmonary embolism. It's just a cough thing. That's a reflex. So coughing is going to come up. But here's a unique one: a frothy, blood-tinged sputum. Hemoptysis. That's the one that you got to remember. So med term comes in handy. Chest pain and a rapid irregular pulse. Now, I got to tell you something. Whether you're dealing with myocardial infarction, angina, pulmonary edema, pulmonary embolism, all of these things. Oh, and by the way, let me just go one more. Something called pleurisy, also known as pleural effusion, which we haven't jumped on yet, we will. Pneumonia, like I just laid out, 6 different things. Every one of them is going to say chest pain right next to it. It's a dangerous, murky lake that you're wading into. Be careful. Take only what they give you. Don't add to the situation. That's a big thing. If it says cough, then you're like, yeah, I know, I get it. If it says chest pain, say, gotcha. What else does it give you? Find the key elements that help you to understand. Maybe that's where what was going on with that patient before. Maybe it's where they're at now. But see about the key elements before you do anything else. It really picks on, for pulmonary edema, the bloody cough. That's not something you're going to see with a pulmonary embolism. It's not something you're going to see with a heart attack. It's not something you're going to see with chest pain like angina. It's not something you're going to see with pneumonia. Do they cough with pneumonia? Heck yeah. But if they have a bloody cough, different story. Plus, I'd also say this. Bacterial pneumonia means you have an infection. You're also probably going to see something like fever. These other things, all this other stuff that we talked about, these emergency things, they don't have fever. That's not something that came along with it. I'm not saying it couldn't. I'm just saying that's not probably the scenario they're going to paint in. All right, so one more time. Where are you gonna see the edema on a right side heart failure? Lower extremities. Where are you gonna see the edema on a left side heart failure?
Pulmonary, the lung. You can't see it, right?
Huh?
You can't actually see it.
Nope.
Okay.
Not until they coughin' it up, and then you can see it.
Right.
Because you're like, why are you coughing up blood, dog?
Right.
Alright. I've got $1,000 in my pocket. I'm willing to bet you're gonna see those questions. Anybody taking it? I'd love to make money off of you right now. It's happening. You're gonna see it somewhere. Somewhere. It's going down. I would gladly take that bet. I'd even double. You're gonna see pulmonary edema, pulmonary embolism, DVT. Like, they want to see if you can say that person's alive. And if not, they are not going to deem you safe. Huh?
That's a double or nothing. I could just say I didn't have it.
You could. I'll run a report that costs $1 million and find out.
On the report, can you see like what questions weren't graded? No.
Like, you don't see the questions at all after
I
that?
don't think so. They're not going to turn these questions.
I mean, you know what, after that, I probably don't know.
You would think that they would make their own study guide to help people. I mean, I guess they lose money if they done that. No, they make money. Who buys the,
No.
Tomorrow, for your test, are you opening it from like 8 to 12 like you were going to last time? How's that working?
Hang on, let me get out of this car and get into the next one. Do I have my list over there?
Yeah.
What is this gap from 8:30 to 9?
It's all pulmonary edema, the right side is just, you can see the edema.
All I know is Tara and Lindsay, they better be ready.
At 9?
Yeah. Are you kidding me? Aaron and Dakari, they're gonna get bumped so fast.
Well, why don't you move them down then and then start at 8:30?
Because I like things to get done.
They signed up after me too.
What?
They meant to put the gap right.
no, I was first. I was the first one to sign it. Yeah.
No.
Okay, I had a question about lymphedema. So it said adjacent. So does that mean if their right leg is the one that has the messed up lymph nodes, it's gonna go in the left leg, like the edema will be?
All right, that's okay. So one more time then?
I was on one of the questions of our.
They're gonna have ipsilateral edema to the lymph side that's
Okay.
just not correct, or that's abnormal.
Oh, so it goes to the opposite side or no? Oh, okay. Because it said adjacent, I didn't know what that meant.
Are we talking about lymphedema?
Yeah.
Well, Dakari is.
Oh.
Dakari and Tara just like to throw these randomizations at me where I'm like, I'm